Labor and Delivery Part 1. There's a variety of classes available for pregnant women, including parenting, breastfeeding, sibling classes, father classes, teen classes, grandparent classes, childbirth classes, cesarean section classes, etc. Some of the more well-known childbirth classes are Dick Reed, who subscribes to the fear, pain, tension cycle. When you interrupt the cycle with education and relaxation techniques, then you take away some of the pain. The Bradley class is a husband-coached childbirth class where the father is an integral part of the birth. It focuses on slow abdominal breathing and relaxation techniques. And the Lamaze class, which I think is probably the most well-known, uses mental and breathing techniques. Ultimately, what education is going to do will affect a woman's psyche and potentially improve the birth experience for her. Now, there's a variety of factors that can affect the components of the birth process, causing a picture-perfect delivery or alterations in labor, and we're going to discuss them as we go through this module. We need to be aware of the ethical issues in reproduction just because this is probably the most litigated area of medicine out there. There is something called mandated contraception, and this has been used as a condition of probation for women who have been accused of child abuse to avoid jail terms. Fetal injury. If the mother's action causes injury to the fetus, should the mother be prosecuted? It's just coming into being that if the fetus is killed during a murder of the mother and the fetus was viable, many criminals are now being charged with murder of the fetus. Fetal therapy refers to intrauterine procedures such as blood transfusions, which really is a fairly common practice. And fetal surgeries are still uncommon, but they can be performed, such as surgeries for fetal anomalies such as spina bifida. And infertility. We have to look at the ethical issues of treatments. If the parents divorce, what happens to the embryos? If the parents die, what happens to the embryos? Cases with more fetuses than can be expected to survive. And surrogacy. Within the last few years, there was the big to-do about the woman in California who was impregnated with 8 fetuses, if I'm not mistaken, and a lot of criticism came about because this woman was a welfare patient or welfare client, and was it ethically responsible to implant her with so many embryos? And the legal issues. Don't forget the Nurse Practice Acts, and again, you should have a copy of your State Practice Act. The National Council of State Boards of Nursing, the NCSBN, at www.ncsbn.org, has information on all Nurse Practice Acts for all states and the District of Columbia, as well as U.S. territories. Every state has one, and it delineates methods called standard procedures. We have to look at the standard of care. Many organizations on national level help set the standards of care and practice. Perinatal nurses are held to national standards published by A1, the Association of Women's Health, Obstetric, and Neonatal Nurses. And agency policies are rules and policies set by the institution that employ the nurse, such as a policy to administer Pitocin after delivery, or the amount of time a client is kept on the birthing unit after delivery if they're on magnesium, and etc. Accountability is the most common recurrent issue regarding inadequate staffing. Competency is also involved in the accountability aspect. A nurse has to be competent to perform a nursing task. For example, a nurse immediately communicating to a physician that a fetus is showing signs of distress is an example of accountability. Sentinel events are unexpected occurrences involving death or serious physical or psychological injury or the risk thereof. Serious injury specifically includes loss of limb or function. These events are going to require immediate investigation and intervention, and examples are maternal death related to a birth, any perinatal death unrelated to a congenital cause in a newborn that weighs over 2,500 grams, or an infant being discharged to the wrong family. Following investigation and intervention, a plan is then developed to help reduce future incidences. A failure to rescue is a failure to recognize and act upon any situation which may cause adverse effects in the outcome of the obstetrical client and the fetus and newborn. Key components: careful surveillance and identification of complications, and acting quickly to initiate appropriate interventions and activating a team response. This does include timely recognition of complications, appropriate interventions, and team management. Examples are placental abruption, postpartum hemorrhage, eclampsia, non-reassuring fetal heart tones and pattern, prolapsed umbilical cord, etc. With perinatal nursing, many malpractice cases are the result of complications resulting in long-term disabilities. This is, again, one of the most highly litigated areas of practice. So how do we avoid malpractice claims? Well, we start off by making sure we have informed consent. Make sure that the three components are met in order to consider an informed consent. The client must be competent, have full disclosures of information, and the client must understand the information. For example, the nurse goes into the pregnant client's room and assesses the client. The client is alert, oriented to person, place, and time. Then the nurse reviewed the chart and noted the client had not received any mind-altering medications within the last 8 hours. The nurse explains the need for the C-section procedure due to the lack of labor progression and the possible risk associated with the procedure. The client denies any questions and verbalizes understanding of the procedure and the possible risks. Is this an informed consent? Yes, the client is competent. Full disclosure occurs, although by not the appropriate person, but again by an equally competent person, and the client verbalized understanding. Refusal of care. An example is a client refuses pain medication after giving birth. The client has that right. Documentation. It's critical that the specific and complete It is critical that documentation is specific and complete because of the long statute of limitations when a newborn is concerned. I think it's up until that newborn is 18 years of age or somewhere in that. Don't quote me on it, but I know it's a long period of time. If sued, you are going to have to rely on your documentation to tell the story of what occurred, because most nurses are not going to remember specific incidents years later. And make sure that you include fetal monitoring, phone calls that have been made to the physician, conversations with the client and family, new orders, discharge teaching, incidents to the client, visitor, or staff member. Remember, you are an advocate for the client. You can lose a lawsuit if you did not appropriately advocate for your client. Make certain that you document all efforts to seek help for clients and all channels involved. And maintaining experience. Continuing education hours are really important because information changes extremely rapidly, so you have to stay current and read journals, all those seminars, etc. So let's start talking about labor and delivery. First of all, we need to know what the warning signs are because we need to educate our clients. Labor symptoms are prior to 37 weeks gestation or 38 weeks gestation that persist despite changing position, hydration, and extra strength Tylenol. These are warning signs. They could be indicative of preterm labor. Flu-like symptoms, such as nausea, vomiting, and diarrhea. They may be symptoms of labor because part of the labor process is to clean the body out to make more room for the baby. Dehydration can cause contractions, so mom has to be certain that she stays very well hydrated, and it's usually more than what mom thinks is appropriate. Infection symptoms. A temperature over 100.5 degrees, pain or burning with urination, an odorous vaginal discharge, or purulent vaginal drainage. These can all be symptoms of an infection and definitely need to contact the physician. Mom will handle infectious symptoms much better than a newborn can. And bright red vaginal bleeding with or without pain. If it is with pain, it's potentially a placental abruption. This is where a normally implanted placenta separates from the uterine wall prematurely. In other words, before the baby's born. Mom might experience abdominal or back pain that continues to increase in severity. There may be some bright red bleeding or no bleeding dependent on fetal head engagement. If the fetal monitor is on, you may note initial fetal heart rate acceleration, then deceleration to bradycardia, and asystole if the problem is not corrected. You may note sudden violent fetal movement within mother's belly. Mom might develop symptoms of shock. She may have conditions such as hypertension, cocaine use, cigarette smoking, or maternal abdominal trauma that will increase her risk for an abruption. An increased risk for DIC, which is the disseminated intravascular coagulation, infection and hemorrhage. The DIC risk usually will resolve quickly following delivery of the fetus. The extent of the abruption will determine the outcome. Usually it requires an emergency cesarean section, oxygen, intravenous fluids, repositioning of mom. And then placenta previa is bright red vaginal bleeding without pain. The placenta is implanted in the lower portion of the uterus and covers all or a portion of the cervix. As pregnancy progresses, the fetus will put pressure on the placenta, and normal cervix and uterine changes will disrupt that placental attachment. In other words, it starts coming loose. Excuse me. Some risk factors would be advanced maternal age, a previous cesarean section, multiparity, cigarette smoking, and a history of abortion. Mom may be placed on bed rest to allow the pregnancy to progress if the bleeding is not too severe. No vaginal examination should be done because it can also disrupt the placental attachment. The woman is also at an increased risk for infection or hemorrhage and usually will require a cesarean section. Depending on the extent of the bleeding, there may be an emergency hysterectomy. And the last warning sign is the feeling that something is wrong. Never discount a woman's complaints if there is nothing positive or tangible proof of her not feeling right. that she feels something is wrong, because a lot of times these mothers tend to know. Some labor initiation complications would be preterm labor, which is after 20 weeks and before 37 weeks gestation. There is an increased risk of infant morbidity and mortality. We have to treat mom with activity restriction and tocolytic therapy. Tocolytic therapy will relax the uterine muscle. 3 of the main ones that are used is magnesium sulfate intravenously, terbutaline or breathine, which is actually an off-label use, and it's administered either subcutaneously or orally. Makes mom real shaky though. And nifedipine or Procardia, which is a calcium channel blocker. Often in instances of preterm labor, we administer glucocorticoids such as betamethasone to help increase fetal lung maturity. It kind of speeds that maturity up. A premature rupture of membranes is a spontaneous rupture of membranes at term more than 1 hour before contractions begin. One of the first things we do when mom comes in is in our history is ask if she's had any leaking of vaginal fluids. If the answer is yes, or it's positive, then we can test it with nitrazine paper. Nitrazine paper is an acid-base balance paper, and if the vaginal secretions are amniotic fluid, it will turn a dark blue. You can also put some of the fluid on a microscope slide and look at it underneath the slide, and you'll see a ferning pattern. If it is amniotic fluid, that ferning pattern is present. These women are at an increased risk of infection. And after the rupture of membrane, spontaneous or artificial, it's really important to always check the fetal heart tones and do a vaginal exam to make certain that the cord has not prolapsed. If the fetal head is not engaged into the pelvic outlet, it might allow the cord to sneak down that birth canal, and that can cause some significant issues. Oligohydramnios is a decreased amount of amniotic fluid. There's an increased risk of umbilical cord compression with this symptom, and that can increase fetal hypoxia. A prolonged pregnancy. We consider a baby to be post-mature if gestation has gone on 42 weeks or longer. The placenta usually will begin to age, and it will provide decreased nutrients and oxygen to the fetus, so the fetus begins to lose weight and loses some of that subcutaneous brown fat. The skin begins to peel and the nails will grow really long. In this picture here in the lower right hand corner shows that excessive skin peeling. There is an increased risk of the fetus passing meconium in utero. There's decreased newborn blood glucose at birth. And the fetus doesn't tolerate the labor process as well because of those decreased reserves. But if the placenta does continue to function well post-term, the fetus can be very large. Indomethacin is not commonly used as it can cause a reduction in amniotic fluid and can actually cause the ductus arteriosus to close prematurely, which can cause fetal death. This is a diagram of the placental abruption showing how the placenta is separating from the wall of the uterus prior to delivery of the fetus. Baby can bleed to death is basically what happens, and potentially mom can suffer hypovolemia and or, depending on the extent, may hemorrhage herself. Placenta previa. Again, the diagram shows the low-lying placenta, the partial placenta previa where part of it covers the cervical opening, and the total previa, which covers the entire cervix. Different signs of labor. We don't always look at one particular sign as being the start of labor. The more signs that a woman has, then the more likely it is that she is actually in the beginning stages of labor. Never again discount any of the symptoms that mom is showing, but you always try to offer encouragement because can be a very stressful time. Mom is tired of being pregnant, she's ready for labor to start, and you're telling her no, that it's not starting. You've got to be very understanding and very empathetic as you deal with her. Braxton Hicks contractions are irregular contractions that begin during the second trimester. They can be really uncomfortable, and they are more common in multiparas. As for false versus true labor, always remember that labor is not diagnosed until progressive changes are made in the cervix. So when mom has contractions, you need to know the duration, the intensity, and the frequency. One of the most common questions you would hear as an OB nurse is when mom should go to the hospital. A lot of women feel that as soon as contractions start, that labor's starting, I need to be at the hospital yesterday. And that's not always the case. Usually we encourage women to stay at home until contractions reach certain parameters. But we always toss the aside in there that, if you would feel more comfortable being here at the hospital, you're certainly welcome to come at any time. Now, when we're discussing bleeding in pregnant women, understand that bleeding in pregnancy is defined as not mixed with mucus. Multips are usually encouraged to go to the hospital earlier than primeps. Women are also encouraged to go to the hospital if they feel decreased fetal movement or, again, mom has any other concerns. So, induction of labor. This can be a touchy topic. Induction and augmentation of labor use artificial methods to stimulate uterine contractions. If the woman's body is not ready for labor or the cervix is not favorable, induction may be unsuccessful. Cervical ripening is often done prior to induction to help improve the chances of success. And to measure how ready the cervix is or how favorable it might be for induction, the physician often does a Bishop score. And this is basically a scoring system, again, that just determines how ready the cervix is. Table 8.1 in your book shows that scoring system. Augmentation is defined as the artificial stimulation of uterine contractions that have begun naturally. Examples are rupturing the amniotic sac without effective uterine contractions beginning and then stopping, or contractions that might slow down in frequency and strength. An amniotomy is usually performed in conjunction with induction and augmentation of labor to allow fetal monitoring. It can also be used to initiate labor. An amniotomy is the artificial rupturing of the amniotic sac. It's performed using a plastic hook to perforate that amniotic sac. We want to make sure that we put pads underneath mom because usually it's quite messy. Explain the procedure and that the amniotic sac is fetal tissue, it's not maternal tissue, so it really doesn't hurt. Amniotomies do place limitations on the labor because now mom must deliver within a specified time frame, and it does increase the risk of infection. This is a procedure that's always done by the physician. Now, if it is done too soon before the fetal head excuse me, before that fetal head is situated in the pelvic outlet, then that cord can prolapse. The rupture of the amniotic membrane can also have an adverse effect on the fetal heart tones, and that's why we always recommend that the nurse check fetal heart tones for at least a couple of minutes following an amniotomy. Now, an amniotomy excuse me, will remove the cushion between the cervix and the fetal scalp. So usually beginning with the next contraction, the fetal head now potentially slams down onto the cervix and labor becomes much more intense with the first contraction. Prostaglandins. Prostaglandins are used, or what we use, to soften or ripen the cervix for induction. It can cause it to, in addition to soften, to begin to efface and or dilate. If the cervix is ripe, then it's going to be a lot more likely to begin dilating. We place prostaglandin next to the cervix once or at scheduled intervals until the until the labor pattern is established. Prostaglandins can also be given orally. The three most common types are Prepidil and Cervidil. Those are both vaginal. One is a gel and the other is medication is on a little tampon with a string. And Cytotec, which is the pill. And Cytotec is actually, as a prostaglandin, is an off-label use, and it was originally designed for peptic ulcer disease. So when these are placed intravaginally, we put mom on the fetal monitor. We obtain her vital signs every 15 minutes. She must lay flat for 1 hour to prevent dislodgement of the prostaglandin, and she has to remain in bed for the second hour, but now she can raise her head. Mechanical methods of labor induction would be like your Lamisil or your Dilapan, which are placed in the cervical canal, and they absorb water. And as they absorb water, they're going to swell gradually and dilate the cervix. The physician may also strip the membranes, which involves inserting the finger into the cervix, into the uterus, and running the finger between the amniotic sac and the wall of the uterus. Oxytocin is one of the main induction medications that we utilize. It is the naturally occurring hormone in the body, but now we begin to use it for our excuse me, I keep losing my voice. So we use the synthetic form called Pitocin. We start out slowly and gradually increase the oxytocin IV drip rate to stimulate uterine contractions and increase the frequency of the contractions. We monitor uterine activity, fetal heart rate, and fetal heart patterns before, at the start, and throughout the labor. Oxytocin will leave the system very quickly, so when we turn it off or turn it down, then it allows the regular pattern to come through or contractions stop altogether. Oxytocin can cause hyperstimulation, as can prostaglandins. And hyperstimulation of the uterus, in other words, having contractions more than one every minute or at every minute, is considered hyperstim. It can cause fetal distress because the baby is basically not getting any air. So we turn the oxytocin off. If this doesn't work, then we can also introduce some tocolytics to relax the uterus. Terbutaline is one of the most common ones when we give it sub-Q. With prolonged administration of oxytocin, the uterus will become desensitized to the oxytocin. Once labor has reached its active phase, labor is usually self-sustaining at this point, and increasing or continuing the oxytocin infusion may not be of any benefit. So when should we induce labor? When a continued pregnancy puts the woman or the fetus in jeopardy, but only if the delivery of the fetus can wait until the length of the induction process. Other reasons would be an intrauterine fetal growth restriction, maternal fetal blood incompatibility, a premature rupture of membranes, a post-term pregnancy, choriamnionitis, which is an inflammation of the amniotic sac, hypertension, maternal medical conditions that worsen if the pregnancy is continued. Induction for convenience is not recommended at all. So these women who whine and complain because they're tired of being pregnant is not a reason to induce them. This is a picture of the amni hooks that are used. Contraindication of labor induction. Any contraindication of labor or a vaginal birth is going to be a contraindication to induction or augmentation. Placenta previa can cause hemorrhage during labor. Vasa previa, fetal hemorrhage is a possibility if the membranes rupture. Umbilical cord prolapse, it indicates a need for an immediate cesarean to stop cord compression. This prolapse is where the cord will deliver prior to the fetus, and there's compression of the cord that cuts off the flow of oxygen to the fetus, and it can result in fetal death. You have to relieve the pressure from the cord and maintain that position until delivery. Abnormal fetal presentation or abnormal size and structure of the pelvis makes a vaginal birth more hazardous. The fetal presenting part is above the pelvic inlet. It may be associated with cephalopelvic disproportion or a preterm fetus, or a previous upper uterus surgery. An example would be the classic cesarean incision, where it goes up and down instead of transverse, or maybe an extensive surgery for uterine fibroids. There is an increased risk of hemorrhage or uterine rupture. Serial induction of labor. It's used when the cervix is not favorable and the woman has indication for induction, but same-day delivery is not imperative. In other words, a good example would be a woman who is expecting a large fetus. If the pregnancy is allowed to continue, that would be too large for her to deliver naturally. Oxytocin solution is given over a 2 to 3 day period for 8 to 10 hours each day. If labor has not progressed, the infusion is stopped and a woman is given a light meal, and the infusion is started again the next day.